Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. On the podcast today, I'm joined by our deputy editor Nick Bostock to talk about some of the latest news affecting general practice. Coming up, we're talking about how the BMA plans to respond when details of the 2026-27 GP contract are published, which are expected at some point this month, including what could happen with any further action by the profession. We're also discussing confusion about the timeframe for neighbourhoods, as well as how plans to ramp up advice and guidance could bring even more work to general practice in the coming year. And we're talking about a couple of stories we've published over the past week or so that show the increasing pressure GPs are under, including the difficulties many doctors have managing childcare arrangements as a result of work. Managing a practice right now is a balancing act. That's why a team subscription to GP Online is a smart investment. Not only do you get access to GP Online, your team can access MIMS for their prescribing information, MIMS learning to manage their CPD, and GP Business for practice management advice. That means expert advice on red flags, news updates, HR, finance and contracts to keep your practice running smoothly. Support your staff and protect your business. Check out our team subscriptions at GPonline.com. So first up, Nick, let's talk about this year's GP contract. So this is the 2026-27 GP contract. The BMA said last week that it expected details of that contract to be published at some point this month, didn't it? That was at an online meeting it held for GP partners. Why was it holding that meeting?
The BMA held a couple of webinars to talk to GPs about a mix of things. Current pressures, looking ahead to the GP contract for the next financial year, and then more broadly talking about the future of general practice in the context of all the change that's currently taking place in the NHS. Leaders of the BMA England GP committee talked through the implications of promises to move resources out of hospital under the 10-year health plan, GP access, development of neighbourhoods and so on. And the committee said they're expecting the contracts for 2026-27, so that's the financial year that's coming up, to be published this month, so in February. So the committee will meet around that time, towards the end of February, to discuss what's in it. I think it's fair to say that this year there's a lot more uncertainty around changes because of the ongoing dispute between the GP committee and the government, which has meant a much more limited role in negotiating the deal. But having said that, we're not expecting massive changes this year in any case. They also talked about the possibility of a return to collective action to put pressure on the government. We know some GPs are not happy that some form of action hasn't started already. LMCs voted at the end of last year for a ballot on stepping up action and considering measures like full-day walkouts, but there hasn't actually been any movement on that so far. I think the GP committee recognises that frustration, but it's previously made its position clear on sort of why they're holding fire for now. And GP committee chair, Dr. Katie Bramall, reiterated that position at this meeting. She said that in the midst of winter pressure, the run-up to the end of the financial year and all of the quaff pressure that brings for practices, they just don't feel now is the time.
So what's the BMA's position on this year's contract? As you mentioned there, we know the GP committee hasn't been involved in the same way it usually would be in how the contract is developed. So it's very likely, they might not see anything about what's in the contract until it's actually released, and they may not even get a heads up about when that's going to happen given the current state of things. So what's going to happen when details of that contract are published? What's the BMA going to do?
What the BMA said is that when the contract is published, so like we said, it's probably towards the end of February, the GP committee will meet and it'll decide then on its response. One option is to repeat what happened 2 contract cycles ago, a referendum of the profession, and then potentially a return to the collective action that we saw from summer 2024 into the start of last year. I think that's probably the most likely outcome, some kind of consultation with the profession on next steps. Forms of action that involve a breach of contract, things like full-day walkouts, those sort of actions would require a formal ballot. And I think the BMA for now is quite wary of going that far. A referendum could, in theory, test GPs' willingness to go for stronger action along those lines. But the advantage of the types of action, collective action GPs have taken part in so far, is that they don't breach their contract, so there's much less jeopardy for partners. At the same time, they're still able to send a message to government and put pressure on other services in that way. We've talked before about what the BMA wants from this year's contract. £50 increase in funding per patient, for example, partnership premium to incentivise doctors to stay in partnership roles, funding at practice level to support recruitment may be taken out of something like the ARRS type scheme that exists at the moment. Measures to end the dispute over having online consultation systems on throughout core hours as well. And that big funding rise seems hugely unlikely, and I would have thought measures like a partnership premium probably are similarly unlikely. We've talked about this a little bit before on the podcast, but they're unlikely to be adopted at the moment just because the government seems more likely to do something to incentivise new models like neighbourhoods instead. We're expecting limited change for now. What the government has said is that it's currently planning a 2.5% increase in doctors' pay. That's something that doctors' leaders have called insulting. That sort of level could change depending on advice from the Doctors and Dentists Review Body, which advises the government on pay. And I think we might see some changes to QOF as well, because a minister said recently that they were looking at proposals to update the QOF, which align with the 10-year health plan's focus on moving from sickness to prevention. So not quite clear what that might mean, but we might see some changes on that front too.
If we do get towards collective action again, what kind of collective action will we be talking about if GPs vote against the deal and for taking action? Local collective action never really stopped, did it? But many GPs want there to be some form of national action about all of this, don't they? What kind of things could we be looking at?
The collective action GPs took part in from summer 2024 to early last year, like you said, that continued locally since then. That action involved choosing from a menu of options. There were, I think it was about 10 different options that were on a list that the BMA put out. And the options included things like adopting BMA safe working advice around longer appointments or limiting numbers of patients GPs see each day, that kind of thing. There are also options around stopping non-mandatory services, like enhanced services, particularly where they were unfunded or underfunded. And there are also things like delaying sign-up for pilots or government programs, but again, always without breaching contract. Some of the feedback GPs gave from that first wave of action, according to the BMA GP committee, included a concern that there were just too many options. This time, it looks like if there's a return to collective action, the BMA is likely to focus on just one or 2 points. So a much narrower, tight focus on specific actions that they'd hope that everybody get on board with. I guess, in that context, choosing something that large numbers of practices are really happy to sign up for is going to be key.
Yeah, I suppose that's really important as well, isn't it, with the communications about all this? Because if all practices are doing different things, it's very hard to put across a national message about collective action and why general practice is doing that. And if everyone's doing the same thing, it makes it much easier to tell that story, doesn't it? Did the BMA give any sense on what this year's contract might contain at that meeting, or any suggestion about what practices should prepare for? Or are they really out of the loop in terms of what it's likely to be this year?
I think the BMA really is largely in the dark about what will happen. I mean, like I've said, I think it's quite likely changes will be limited. Probably not much of an uplift funding-wise. There might be changes to the QOF, maybe some changes to other targets. But the BMA has submitted its modelling. It's set out publicly and in a meeting with government and NHS officials about what it wants to see from next year's contract. But what Dr. Bramall said on the webinar was now we'll have to wait and see. So I really think they don't know what's going to be in there in the way that they might normally if they were having more regular meetings and more to and fro with government and NHS officials.
Obviously, the other thing that will impact on the GP contract in the next year or so is what happens to neighbourhoods. We were expecting those new neighbourhood contracts at the end of last year and details of what a so-called model neighbourhood should look like. But the BMA GP committee raised the prospect of those contracts not being available until April, didn't they? What did they have to say about that?
Initially, the expectation was that neighbourhood contracts would be published from November last year. We've since had predictions that they'd appear in January. January's come and gone, and they're still nowhere to be seen. The BMA GP committee is now expecting contracts to come out in April, so at the start of the coming financial year. So that was the latest message we got from the webinar.
Do we know any more about these contracts? We've talked a lot about all the uncertainty that these new contracts are causing GP practices on the podcast in recent weeks and months. Surely it's not going to help anything at all if these contracts don't appear until April.
We've actually reported on a bit of new information on that just this week. An eagle-eyed lawyer from Hempson's, a law firm that specialises in primary care, spotted a line in some technical guidance on the NHS standard contract which is basically the type of contract NHS commissioners use to purchase pretty much everything other than primary care services. The 10-year health plan talked about two new contracts, one for multi-neighbourhood providers, or MNPs, which are expected to cover these large populations of around 250,000 patients, and then another for single neighbourhood providers, or SNPs, which are likely to cover a PCN-sized footprint of about 50,000 people. But what this update to the guidance on the NHS standard contract suggests is that instead of having a standalone contract for MNPs, they're likely to be commissioned through what is effectively an amendment to the standard NHS contract. What that means is that organisations already holding an NHS standard contract, and Hempson says all NHS trusts, most large GP federations too, would already hold one. Those organisations could have a bit of an advantage in making the move to become an MNP. Lawyers say the government would have to consult on this amendment to the contract in the next week or two, potentially, to have it ready for the start of the coming financial year. So for it to be in place from April, when the BMA was sort of expecting, it still seems likely that SNPs, the PCN-sized neighbourhood provider structure, could operate under a standalone contract, but there's no information about that as yet. So GPs are still very much in the dark in terms of how these structures will be funded, how they'll interact with each other, with ICBs and with practices. And in fact, even though we've got this little bit of information about MNP contracts potentially functioning as a kind of add-on, like a bolt-on to the NHS standard contract, we still don't really have any detail about what's in them, how they're funded, those sorts of key questions. There's more on that story on our website at GPonline.com for anyone who's after a bit more detail on some of the ins and outs of that particular update.
We'll put a link to that story in the notes for this episode. The other thing we're probably expecting from April is that ICBs, integrated care boards, will be expected to ramp up the use of advice and guidance. The medium-term planning framework for the NHS says that ICBs should prioritise use of advice and guidance in the financial year ahead as part of a move to all referrals going via advice and guidance for the 10 specialties at provider level which have the most potential for this model to be effective. That was a quote there. We're going to come on to talk about pressure that practices are under, but advice and guidance has really added to workload in general practice in recent years, hasn't it? And there are some concerns about what could happen in the year ahead too.
Our senior reporter, Kimberly Hackett, spoke to LMCs about this issue. And what they said was that the money involved, the £20 per request that practices are paid under the Directed Enhanced Service for advice and guidance that came in at the start of the current financial year, is just not enough to cover the workload involved. And they said that the workload involved is really significant because there are often multiple rounds of messages exchanged between the practice and the hospital as part of an advice and guidance request, as well as then work practices are asked to carry out. We reported before the DES began that practices were worried about the level of funding. Advice and guidance has been around for some time, and previously there was no national funding mechanism to support it. But in some areas, ICBs were offering funding, and that funding was in some cases well above the £20 per request offered through the DES that had been in operation during this financial year. So GPs have felt from the outset that this enhanced service was underfunded, and with plans to expand it more next year, concerns about workload and funding are really high on the agenda. Those concerns have actually had an impact on uptake of the advice and guidance DES too. LMCs say that some practices just aren't taking part because they just don't think the workload is manageable with the level of funding on offer.
Obviously, the reason the government wants to expand the use of advice and guidance is part of a drive to bring down waiting lists and waiting times. Is it working? You've been looking at some of the stats on this, haven't you?
One GP told Kimberly that the advice and guidance DES was not the magic bullet that the government hoped. The government would say that the waiting list has come down. It doesn't necessarily link that directly to advice and guidance, but the increased use of advice and guidance as a result of contractual changes this year is probably something it would point to as a factor that's helped. Although the waiting list has fallen a bit, there are still 7.4 million people waiting, which, only a few years ago, that would have been considered an absolutely unthinkable number. I had a look at some of the NHS data on advice and guidance last week, and what that suggests is that although there's been a rise in requests through this system since the DES took effect in the current financial year, it's not on the level that the government wanted. I looked at figures for the first half of the current financial year, so from April to September, because basically beyond that, the data is sometimes a little bit unreliable. It just takes a while. There's a lag in the figures being updated as information flows through from NHS organisations locally. But what those figures show is that only 1 in 4 ICBs were on track to spend their full share of funding from the Advice and Guidance DES. Nationally, at the halfway point in the financial year, enough requests have been made to claim about 41% of the £80 million funding pot available through the DES. So requests need to speed up a lot in the second half of the year to use that money up. But actually, that 41% is kind of pushed up by a handful of ICBs where they're way ahead of schedule. So about 10 ICBs are ahead of schedule. But there are some other areas which are way off, and we found that 2 in 5 ICBs had used less than a third of their available funding for the year in those first 6 months. So one thing LMC's told us is that perhaps because of the shortfall, in some areas, ICBs are starting to offer more per request to try and use up the funding and to try and boost uptake of advice and guidance as a whole.
We were talking there about workload pressure in general practice as a result of advice and guidance adding to the amount of things that practices are expected to do. And Nick, you've written a couple of stories in the past couple of weeks highlighting how that pressure is affecting practices and then in turn how it's impacting on GPs. So firstly, you were looking at the latest statistics about appointments in general practice, and they take us up to the end of 2025, don't they? So you've got a picture of the whole of last year. What do they tell us?
So overall, the picture is one of lots of pressure on general practice, perhaps unsurprisingly. 2025 was another record year for total appointments delivered, and that's basically been the case every year for a while now. GP practice in England delivered more than 388 million appointments in 2025. There were 4 successive months at the end of the year with well over 30 million appointments. If you want to get into the detail, there's more detail on the website in terms of the breakdown between standard appointments, the proportion that were for COVID vaccinations, numbers delivered through PCNs. But overall, appointments were up around 2% compared with the year before. And what the figures show is that general practice delivered more than 6 appointments for every registered patient in 2025, which is a lot when you consider that funding per patient comes to less than about 35p per day.
Yeah, and those statistics really hammer it home, don't they? It's not very much money at all for what practices are expected to do. You also looked at data from the Health Survey for England, which also suggests that practices are facing increased pressure. What did that survey show?
I thought these findings were really interesting because of what they show about changes in the population that are likely to be reflected in what GPs see coming through their doors every day of the week. The health survey showed that over the past decade and more, the proportion of people in England living with at least one long-term condition has risen. That's not surprising because we know the population's aging and becoming more complex, but the rise over the past decade and a bit is steep. 46% of people said they had at least one long-standing illness in 2024, and that's compared with 38% in 2012, which is the furthest back comparable figures run to. Other key findings include things like just 72% of people consider themselves in good health. It's good or very good health. That's the lowest figure recorded in more than 30 years through this survey. And then on the flip side, 8.5% of people consider themselves in poor or very poor health. And that's also, that's the highest figure that there's ever been. About 1 in 6 people reported acute sickness in the past 2 weeks, and that's also up from previous years. More people with long-term illness, more people in poor health, more acute illness, and all of that obviously means more work for GPs. And GPs I spoke to linked the deterioration in these figures to factors like the massive NHS waiting list. We talked about 7.4 million people still waiting, long-term underfunding of healthcare through years of austerity from 2010 onwards, as well as an ageing population. They said GPs are left firefighting because of the increased pressure these changes bring. So when we're talking about, the government's ambition to move towards more prevention and doing more stuff upstream, At the moment, it's a tall order because GPs are dealing with day-to-day so much reactive work to do that finding space for proactive care, for preventive work, is just that much more difficult.
All of this pressure obviously takes a real human toll on GPs and people working in general practice, doesn't it? You wrote about results of a poll recently that found 1 in 6 GPs have had to leave a job because they've been unable to balance childcare with work. I mean, this poll comes after that very high-profile case at the start of January of GP Dr. Helen Eisenhower, who was suspended for 5 months for misconduct by the Medical Practitioners Tribunal Service after she booked false appointments into her schedule to make sure she could leave work on time to pick up her children. There was an outcry from many doctors about the severity of that sanction. No one was condoning that GP falsifying records, but many people spoke out at the time about the challenges of balancing a career in medicine with family life and childcare, which will often, obviously, disproportionately affect women doctors. I mean, what did that poll actually find?
This was a survey by the website doctors.net, and they shared a breakdown of responses from GPs with me. The GP you mentioned, who made up a couple of appointments at the end of a working day because she was worried about getting out of work on time to pick up her children, her case really struck a chord with many GPs because although, as you said, no one's saying falsifying appointments is okay, huge numbers of GPs recognise the situation she was in. If the last patient who comes through the door on a given day is complicated and needs time, leaving work late becomes inevitable. And what this survey showed was just how widespread that experience of struggling to balance work in general practice and childcare or family life really is. It found that 1/6 of GPs have quit a job at some point because they struggle to balance work with childcare. 82% struggled to find suitable childcare. 71% had reduced their working hours because of childcare constraints. 93% experienced guilt as they tried to balance childcare and work. One doctor said that without family support, the idea of working full-time in general practice was just impossible. There are other careers in which that's also the case, but the point here is that the NHS, the government, individual practices too, all probably need to do more to help GPs manage that balance.
It's quite ironic, isn't it? We talked about this after that case was publicised, but obviously lots of doctors do choose general practice, and over the years I've spoken to many GPs and many women GPs, and lots of doctors do choose general practice because they feel it's a more family-friendly hours, you're not so much subjected to shift work. But the reality of it is, isn't it, the core hours are 8:30 to 6:30, and obviously having been a parent of young children in the past, I know for a fact that there's hardly any childcare places that are open past 6:30. Even getting to 6:30 is quite difficult. And we also know that GPs often work really, really long hours, and the fact that they can't get away on time is quite a normal occurrence. So it is really difficult, and particularly if you've got a child with additional needs or if you're a single parent, then childcare problems must be very insurmountable to lots of GPs, I would imagine. Well, that's it for this week. Thanks to Nick and thank you for listening. I'll be back next week when I'm speaking to Professor Bolaro Alabi, who became the Chief Inspector of Primary Care and Community Services at the Care Quality Commission last July. I'm speaking to her about the role of the CQC, how the regulator is changing to address key problems identified in some high-profile reports, and why she believes the CQC and regulation has a key role to play in helping to tackle health inequalities. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.